Yeah, great.
Ah,
Yeah,
fine.
perfect. Yeah.
So can I go ahead?
Yes.
Yeah. Before we start, I will the topic. I will start with the options available for treatment of bronchopulmonary dysplasia. As Dr. Murki rightly said, it's really a difficult topic and a voluminous topic. We have so many treatment options available. You have dexamethasone, you have surfactant, you have gentle ventilation, you have diuretics, and so on and so forth. It's really a conundrum to how to manage an infant with BPD, how to prevent and how to treat. In fact, when I looked for BPD just for systematic reviews. So if you look at the systematic reviews here, the bronchopulmonary dysplasia and newborn and just systematic reviews, if you search, you are getting about 384 systematic reviews. This is beyond for some topics, you will not get even that many studies. So on BPD, we have 384 systematic reviews, and basically you need a review of all the systematic reviews. You need a systematic review of systematic reviews, and that's how tough the topic is. And before I continue, I will also like to highlight, this is again another search in PubMed, where I have searched for BPD and newborn and India. So if you look at only at India, you only have 79 results. And that's really unfortunate. We have so many people who are doing so many researches on newborn topics, but BPD seems to be an orphan topic. It's hardly studied. It's only 79 results. Of course, this is not a very comprehensive search. And even among the 79, we have only 31 are review. More than 50% are reviews. So hardly primary studies have been done on BPD in India. So it's rarely a focus in India, and that's unfortunate. So with this prologue, I would start the topic proper. The overview of my presentation would be basically to answer 3 questions. What is BPD? So we'll look at the definition and the burden of BPD. Why we need to talk about BPD? We'll look at we talk about the pathogenesis and the pathophysiology of BPD. And the focus of my talk today would be how to prevent BPD and a few slides on how to treat, because we do not have much to treat actually BPD. Once BPD is set in, we do not have much in our armamentarium to treat. So the major focus of my talk is going to be prevention of BPD. Now, when you talk about what is so when you talk about what is BPD, we'll talk about the definitions and we'll talk about the burden. When we talk about the definition has evolved over the years. Since Northeast described BPD in 1967, the definitions have evolved. These are the summary of the definitions that have been used to define BPD. We talk about the most commonly used definition is given by Shannon et al. In 1988, which is the BPD is a requirement of supplemental oxygen at 36 weeks of postmenstrual age. And remember, this has only a positive predictive value of 63% for an abnormal outcome at 2 years of age. But still, this got stuck and everybody started using supplemental oxygen at 36 weeks. This was followed by the currently commonly used definition, that is you can call this the NIH definition, National Institute of Health US definition, or NHLBI, that's National Heart, Lung and Blood Institute, the NICHT collaboration definition. And we'll talk about that later in the subsequent slides. The definition was provided in 2001. And recently, the NICHT workshop, the National Institute of Health, their workshop, they suggested some modifications to that 2001 definition. We'll talk about that as well in the subsequent slides. So these two are the most commonly used definitions. But as a fellow, you should also know about other definitions which are probably more useful in research setting, which is the physiological definition, the Walsh et al., and something which has been recently modified to that Walsh definition, that is 2019, provided by Swedenkrantz, which is based on the saturation or the shift of oxygen hemoglobin dissociation curve. And these two seem to be the most defined in terms of physiological definition. And something which has come up by Jensen in 2019 is much simplified version of the NACHD 2018 definition, but possibly not well accepted. So if you look at 2001 definition, that's what most people have been using, and most research projects do use this definition. So if you look at less than 32 weeks, you have to assess to define as BPD, you have to assess at 36 weeks of postmenstrual age. And for that, the baby has to require at least 21% oxygen for 28 days. The more than 21% oxygen for 28 days, then only the baby fits into the bill of BPD. And you assess at 36 weeks. At 36 weeks, baby has received 21% oxygen, more than 21% for 28 days. But the baby has received oxygen for 28 days. And then the baby is, at 36 weeks, the baby is not requiring oxygen, then that is mild. And then depending upon the requirement of oxygen at 30% or more than 30%, or ventilation or CPAP, we can classify as moderate and severe. So this is what we have been using. So mild, moderate, and severe BPD, depending upon what the baby is requiring at the time of 36 weeks of postmenstrual age. And the prerequisite is that the baby should have received 21% oxygen for 28 days. And this definition had its pitfalls. We cannot go into that because our primary focus is prevention. So if there are some suggestions that have been suggested by the NACHD workshop in 2018, the major suggestions are, one is the 36 weeks postmenstrual age remains same, but the baby has to have evidence of parenchymal lung disease, and the baby has to require oxygen for at least 3 consecutive days. So the oxygen requirement for 28 days is not there anymore. So the baby has to require oxygen for at least 3 consecutive days to have a saturation of 90 to 95%. And mild, moderate, severe has gone. Now, instead, we have 1, 2, and 3 grades, and depending upon what support the baby is getting. So roughly, if the baby is getting more than 21% or the baby is on ventilator, that's grade 3. And the baby is getting more than 30 FiO2, 30% FiO2, and the baby is on CPAP or NIPPV or high flow cannula, then that is a grade 3. And 21% with these settings, then it is grade 1, and in between is grade 2. So, and then you have for hood oxygen and then nasal cannula of different flow, you have different grades. What it has also added is 3A, which is basically a baby has died before 36 weeks postmenstrual age, but after 14 days. So the baby had enough time to develop BPD, evolving BPD, but the baby has not been diagnosed to have BPD because the baby died before 36 weeks. In that case, you have a special connotation that is 3A. So you can go on into the details, but that's what the NACHD definition is. So the future studies possibly should be looking at these grades rather than mild, moderate, severe. But of course, it's going to be a difficulty in integrating the data with the previous definitions. Now, with that definitions, whatever definitions we are going to use, but predominantly the NACHD 2001 definition, if you look at the national networks across the globe, this is looking at the incidence of BPD in less than 32 weeks of gestation. And on y-axis, we have the incidence in a percentage, and on the x-axis, we have the different countries, the collaborative networks from different countries, from Australia, Canada, Israel, Japan, and so on and so forth. So roughly, the incidence seems to be 15 to 30% in less than 32 weeks. So less than 32 weeks, the incidence is roughly 15 to 30%. So you can say roughly 1/4 will have BPD. So what about India? So of course, there's no India in that. So if you look at India, so these are the 2 studies which, and one is published from Chandigarh, and that is less than 33 weeks. So it's spuriously low because it's less than 33, and there were the deaths were also quite high. So it's 11%, and the data from our own center, that's from AIMS, it's about 33%, which is less than 32 again, which is compared to that in accord with the previous networks, national networks. So roughly, I would say 15 to 30% in India as well. So roughly, we are talking about 1/4 of all babies who are less than 32 weeks to have BPD. And that's quite high. So 1/4 of babies developing a condition is quite high. And that's why you should know about how to prevent. BPD. So if you look at from what we go to why BPD develops. So pathophysiology, if you look at that, so this is what commonly we have been seeing the pathophysiology of BPD. So everybody knows this figure, but just I will go through that because it has implications for the prevention of BPD. So if a baby is born preterm, the baby requires mechanical ventilation because the baby is at risk of respiratory failure. So the baby is at risk of respiratory failure and the baby requires ventilation. In that case, ventilation leads to barotrauma, volutrauma, rheotrauma, and other traumas. So if we look at volutrauma, so excessive tidal volume will lead to volutrauma. And the baby is also going to require oxygen. So high oxygen will lead to oxygen injury, and that lead to oxygen toxicity, oxygen injury, and compounded by nutrient deficiencies will lead to oxygen toxicity. And the baby has infections, postnatal or intrauterine infections, and that will lead to inflammation fetus release, and then that will lead to inflammation and further lung injury. And the baby, the preterm baby has shown to have a patent ductus arteriosus, and that leads to increased pulmonary blood flow and lung edema. And all these put together will lead to acute lung inflammation or lung injury. And this inflammation leads to damage of all the three components of the pulmonary system. That is the airway, in which there is metaplasia, the vascular injury, there is smooth muscle hypertrophy, and there is interstitial damage where there is increased fibronectin and fibrosis. So basically, the airway is damaged, the vasculature is damaged, and the pulmonary interstitial is damaged. So all three are. Yeah. All three are damaged.
Carry on. I think there is some noise. I'll mute. Yeah.
All three are damaged. That leads to bronchopulmonary dysplasia. So inflammation is a key player in bronchopulmonary dysplasia. So what does inflammation do? So inflammation leads to activation of the pro-inflammatory cytokines like interleukin 6, 8, and TNF-alpha. And that leads to TGF-beta release and proteases and the neutrophils that are increased proteases. All of them lead to fibroblast proliferation, and that leads to in the interstitium there is fibrosis. That's one part. But it also leads to reduced hypoxia-inducible factor and reduced VEGF, and that affects the vascular development. And that's the inflammation that affects both alveologenesis as well as vascularization. So both are affected, and that leads to bronchopulmonary dysplasia. But remember, this classical description of pathogenesis is applicable to predominantly to old BPD, what we know as old BPD. But when we talk about the new BPD, which is what people are saying nowadays, that you have to look at the evolution, the morphogenesis of lungs. So when we know the lungs develop from the embryonic lung bud, that's what we know the embryonic period. And then from there, it goes to the pseudoglandular stage, and then it goes to canalicular stage, and then saccular stage, and then the alveolar stage. So a term baby is born in this phase, alveolar stage. Look at the alveoli, very nicely made, with looking like a cluster of grapes. You can look at this is the AT1 cell or the alveolar type 1 cell, and this is alveolar type 2 cell, well formed. You have a capillary and alveolar capillary unit, and the type 2 cell having a lamellar body that will secrete the surfactant into the lumen, and that reduces surface tension. And that's what the normal alveoli and the lungs should look like. But what happens if a baby is born between 26 and 36 weeks? That's what typically we will be catering to. But those units who are catering to before 26 weeks, the baby will be born even in the canalicular stage. So these lungs are immature. So they have only saccules. They do not have alveoli. And if you look at the microscope, they have the AT1 cells. The type 1 cells are not fully formed. The type 2 cells are not yet fully functional. They do not have the lamellar bodies. They do not have the surfactant production mechanisms intact. And even the capillaries, the alveolar capillary unit is not fully formed. So there is a severe immature lung, which we are talking about. So the immature lung is the key player in a new BPD. So it's not necessarily the inflammation, but it's the immature lung on top of which there's an injury. So this is the model that is proposed for the new BPD. So we have between 0 weeks and 30 weeks and 36 weeks. So we have BPD setting in here. The diagnosis is going to be done here. But before that, there are antecedent modulators that something which can happen pre-conception. Mother had some complications, chronic conditions that can lead to something which will affect intrauterine growth of the lungs. Then pregnancy abnormalities, the preterm birth itself, there's something happening in utero, and that's why that preterm birth itself is happening. And fetal exposures to different stimuli, that leads to some inflammation even before birth. And preterm birth will lead to this, lung, which is saccular stage, at the saccular stage, and it's developing. During this development, you produce injury in terms of polytrauma, in terms of barotrauma, in terms of oxytrauma, and that injury will lead to repair. So injury and repair on top of a development program will lead to a lung injury, which is difficult to repair. And so by the time you diagnose BPD, so many things have happened: injury, repair on top of a development program, and that leads, this injury to the immature lungs leads to what we typically call as a developmental arrest of the alveoli, or a delay, or basically it's an arrested alveolarization. So the alveoli do not get developed further because of the repeated injury, repeated inflammation, and repeated repair mechanisms. So the alveoli just get arrested. And if I have to explain it further, this is a lung section done after a year or so, or 3 years, if I remember correctly. This is a healthy infant. So you look at the alveolar capillary unit, the green, you can look at the alveoli nicely, like a bunch of grapes. The green and the white, these indicate the type 1 and the type 2 cells, and this pink one indicates the capillaries. So it's a nice alveolar capillary unit. This is a microscopy of a lung suction. But if you just compare with the baby with BPD, an infant with a BPD, you can look at the alveoli, how it has been, the morphology has changed. So there is no bunch of grapes anymore. It's like almost like an orange. So you have no more alveolar capillary units that are very well organized. So you can see the capillaries are not well formed. You can see the bunch of grapes has gone. It is arrested alveoli. So that's the mechanism that will lead to new BPD. And that's important. This distinction is important because most of the pharmacological treatments are essentially dealing with the old BPD. Those, we do not have much to reverse, to make it reverse the injury or the fibrosis or the repair mechanism that's happening in the alveoli. And that leads to arrested alveolarization. We do not have much for new BPD, and that's unfortunate. So that's about what is BPD and why it happens. Now we will move into the topic proper, that is how to prevent BPD. So I come back to my original figure, the pathogenesis. So just to understand where our medications and other strategies are going to act. So we have prematurity, so you can prevent prematurity, and you can sort of induce maturation of a premature baby by giving antenatal steroids. And when the baby requires respiratory failure or mechanical ventilation, you can use gentle ventilation. That includes CPAP, non-invasive ventilation, and so on and so forth. So you can do that. When the baby goes on to ventilation, you can polytrauma. So you can reduce by the trauma by giving surfactant. You can use volume ventilation, for example. Oxygen toxicity, you can accept lower oxygen saturations. Injury and the inflammation caused by infections, caused by other mechanisms. You can talk about anti-inflammatory agents, like, for example, steroids. Infections, you prevent infections. You have a lot of bundle approaches to prevent infections. So lung edema, you can talk about diuretics. You can talk about fluid restriction. Airway metaplasia, smooth muscle hypertrophy, you can talk about bronchodilators. So there are a multitude of options. But remember, most of these, as I mentioned previously, is predominantly for old BPD. We do not have much for new BPD. And if I take again, come back to the other figure, if I have to talk about the timeline, so what are the options which we have along the timeline which I described? So from conception to preterm birth, and then from preterm birth to BPD diagnosis, and then later to treatment. So basically, till 36 weeks, you talk about prevention, and once you diagnose, you talk about treatment. So what are the options available from the time of conception to the time of birth? So basically, you have to prevent prematurity. You can use antenatal steroids. You can talk about chorioamnionitis, which can lead to BPD because it's intrauterine inflammation, and IUGR itself. So these are some of the modalities. So of course, this list is not exhaustive, and the most important ones which I'm going to talk about, I have highlighted in bold. And at the time of birth, you can talk about delivery room CPAP or gentle ventilation at the time of delivery itself. Early rescue surfactant, ensure and LISA, the abbreviations have been expanded in the footnotes. So ensure stands for intubate, surfactant, and extubate. LISA, you all know this is less invasive surfactant administration. Then you have gentle ventilation, you have vitamin A, and then you have caffeine. And going on from the time of birth till the baby 2 to 4 weeks, the next 2 to 4 weeks when actually the BPD sets in. So you can have, again, gentle ventilation, steroids. And that because we know inflammation is a key player, so steroids. And fluids, patent ductus arteriosus, nutrition, diuretics.
It's 9 o'clock.
Diuretics, bronchodilators, prevent sepsis. So these are some of the modalities which we have in the later part. And the treatment, as I mentioned before, and I want to stress it again, we do not have much. So we have steroids, optimize the nutrition, optimize the ventilation, and home oxygen. So that's what we have. So this is the timeline along the continuum of care from the conception to the discharge and beyond. So we'll talk about one by one. Well, to start with antenatal steroids. So I am not talking about prevention of preterm birth, because if you prevent preterm birth, as a neonatologist, we do not have any job and we have to change our specialty. So there's no other way. So we have to just stick to think that we cannot prevent prematurity. So we will move on to antenatal steroids. So I'm directly going to the Cochrane review on antenatal steroids. So this is steroids versus placebo. And this all, most of you must be knowing, this is what we call as a forest plot. I will be again and again showing forest plot. So a little bit of explanation what a forest plot. Those who know have to bear with me. This is basically for those who do not know to interpret a forest plot. So here we have the outcomes. So this is the comparison, that is corticosteroids versus antenatal steroids versus placebo or no therapy. And here this is the outcome, that's respiratory distress syndrome or RDS. And this is what we call as the typical forest plot. So you have each study, which is depicted as, you can see a box and then the lines. The box indicates the point estimate or the relative risk, as given here is the risk ratio or the relative risk. And then the lines indicate the confidence intervals. So the simplest way to say is each study, whether this study is significant or not, if this lines cross this, the vertical line, which is called the line of no difference, the null line. So the null line is 1. So if a particular study, the confidence intervals crosses this, that means that study did not show a significant result. Now in a meta-analysis, this is a meta-analysis, the first plot obviously a meta-analysis. So here, how you are going to interpret this, basically you have to look at this diamond. This diamond is away from this null line, the line of no difference or not. So this diamond is clearly away. And you see here, this is favoring corticosteroids. So RDS is less in babies who received antenatal steroids. So if the babies have been exposed to antenatal steroids, the respiratory distress syndrome is reduced. So this relative risk is the pooled relative risk is 0.66. That means there is 34% reduction in the risk of respiratory distress syndrome if you give antenatal steroids. So this is well known, everybody knows. So there's no need to explain further. So this is 34% reduction in ODS. So if there is reduction in ODS, then there should be less need for ventilation. And if there is less need for ventilation, and there should be less BPD. That's what the traditional thinking is. But unfortunately, whether this is true or not, this, if you look at this Cochrane review, this is chronic lung disease or BPD. We have only few studies. The pool relative risk crosses the diamond, crosses the line of no difference. So if you look at the studies, the evidence, and if you look at this relative risk is 0.86, that means 14% reduction, but the confidence interval crosses 1, that means there's no significant reduction. So even though there's a biological plausibility that by reducing ODS, antenatal steroids should reduce BPD, it doesn't seem to do so. There's no difference based on the limited evidence which we have. But why is it so? Possibly there are different explanations, but nobody knows. It's possibly because by saving more babies, antenatal steroids also leads to it reduces the risk of deaths. So when there's survival of more babies, immature babies, in that case, you will have more immature babies surviving, and that babies are likely to develop BPD, and that's why the BPD as such might not change. Death or BPD might change, but BPD as such might not change. But we should also look at the number of babies. It's only 400 and 400 in both. It's only 800 in both groups put together. So we might be treating 800 in one unit possibly in one city. Every day the mothers might be receiving antiretroviral steroids. So this is not the real in that way. This really limited data, and these are old studies, and there is no way we can have new studies on placebo versus antiretroviral steroids. That's just not ethically acceptable. And of course, they use different definitions because these are predominantly before 2001. So the definitions are itself different. So we do not know the exact cause, but these are the possible reasons why antiretroviral do not reduce BPD as such. Now moving on to chorioamnionitis. This is important because many of us forget about the role of chorioamnionitis on the risk of BPD. Why chorioamnionitis should increase the risk of BPD? Because intra-uterine inflammation so inflammation, whether it happens postnatally or intrauterine, should increase the risk of BPD, because inflammation and then injury and then repair should increase the risk of BPD. And this is shown by a meta-analysis of observation studies, in which if you look at overall chorioamnionitis and the BPD is the outcome here, you can see the BPD is the outcome. So you can BPD is the outcome. So overall, so this indicates higher risk and this indicates lower risk. So this diamond is clearly to this side. So this pool relative risk is, this is odds ratio. So it's 1.29. That means 30% increased odds, or I would say here, just forget about the statistics, increased risk of BPD if baby is born to a mother with chorioamnionitis. So that is 30% increase. And whether this doesn't change much, whether it is histological chorioamnionitis or clinical chorioamnionitis, it's almost the same. So there is increased risk, about 30% increased risk of BPD if the baby has been exposed to chorioamnionitis. So how will you prevent chorioamnionitis? So if a pregnant woman presents in PPORM, for example, that is preterm pre-labor rupture of membranes, you give prophylactic antibiotics, you maintain strict asepsis during labor, and you have to treat with the broad, if the mother has, the pregnant woman has chorioamnionitis, so you have broad spectrum antibiotics and you promptly induce labor. So these are general measures. There's nothing specific about BPD prevention. So, but I just had this slide because most of us forget about the role of chorioamnionitis when you talk about BPD. From the time of preconception, now we move on to birth. So at the time of birth, we are talking about CPAP in the delivery room. Why CPAP in the delivery room? When you initiate continuous posterior pressure, instead of intubating the newborn, preterm newborn, we are talking about a preterm newborn. Particularly, we are talking about less than extreme preterm or extremely low birth weight, 28 weeks or less, or you can say it's less than 1,000 grams. Here, the default response when the baby requires resuscitation is to intubate and ventilate. But instead, if you initiate continuous posterior pressure, that is CPAP in the delivery room, you can avoid the BARF trauma and you can avoid the volley trauma caused by intubation and ventilation. And that's the rationale put forward for initiating CPAP in the delivery room. And we'll talk about the evidence in the subsequent slides. So again, I'm going back to the Cochrane on CPAP in the delivery room versus assisted ventilation. This is basically prophylactic CPAP versus ventilation. So predominantly these are studies which are, this is the finer one is the support study, and morally is the COIN study. So you should be fully, as a fellow, you should be fully thorough with the COIN study and support study. And the third one is done study. So put together, these studies put together, you can see the diamond is not touching the line of no difference or the null line. And if you look at the pool relative risk is 0.89, which is favoring CPAP. That means there is 11% reduction in BPD if you initiate CPAP in babies who are less than 28 weeks when compared to just intubating and ventilating as a matter of routine. So if you initiate CPAP even in these extreme preterm or extreme low birth weight babies, you can prevent BPD by initiating CPAP as early as possible. And if you grade this evidence, it's moderate quality evidence that it reduces BPD, and it from the control risk of about 380, it reduces to 340. And if you look at death or BPD, again a moderate quality evidence, it reduces from 470 to about 420. So for every 1,000 neonates in whom you avoid intubation and initiate CPAP, you have about 40 to 50 less BPD. That means you are roughly a number needed to treat of about 20 to 25. That's what we are looking at, which is quite good. So if you talk about a public health intervention, a number needed to treat of 20 to 25, and for a disease like BPD, which is a multifactorial etiology, is quite good. And this is this is nicely sort of summarized by Alan Jobe in his editorial in Journal of Pediatrics in 2005. Don't just do something, stand there. And then this much more important is, there is perhaps nothing more dangerous for the preterm lung than an anxious physician with an endotracheal tube and a bag in his or her hand. So remember this statement by Jobe, that better to stand near a baby who's less than 28 weeks, the CPAP cannula, than with an endotracheal tube or a bag. Now moving on, people thought if CPAP works, why not NIPPV? Because this sort of will give more pressures and will better avoid ventilation. So will NIPPV, that is non-invasive positive pressure ventilation, will be better than CPAP? If you look at NIPP versus CPAP, this is again a Cochrane review by Lemire in 2016. So here we are looking at non-invasive positive pressure ventilation versus CPAP. The outcome is BPD. And if you look at this, the diamond, it's touching the null line. And if you look at the confidence intervals and the relative risk is pooled relative risk is 0.78. That seems to be a reduction, but the confidence interval is crossing 1. That means there's no significant reduction when you compare NIPPV with CPAP. So CPAP is possibly as good. So there are some, if you go further into the details, so if you look at NIPPV versus CPAP in post-extubation setting, that synchronized IPPV might reduce BPD, but overall figure, if I have to put it simply, the NIPPV is not that beneficial when compared to CPAP for preventing BPD. So I'm as good as with CPAP for prevention of BPD. Now, if you initiate CPAP for every baby, but the baby starts requiring having high FiO2 requirement, in that case, you have to think something else. So if the baby requires high FiO2, you initiated CPAP, the baby starts requiring high FiO2, and in that case, if FiO2 becomes 40% or more, we have to think of surfactant. There's no other way how to think of surfactant therapy. Many units use slightly lower threshold, 30%, but that's debatable. But we use 40% FiO2 for if the baby is on just on CPAP. So if the baby is on CPAP and the FiO2 requirement is going on increasing, then you have to think of early rescue surfactant. So from CPAP, we move on to surfactant. So early rescue surfactant is surfactant given within 2 hours. When compared to late surfactant, does early surfactant reduce BPD? So this is again going back to Cochrane. This is 2012. So there are few studies which compared early surfactant with delayed surfactant. The outcome here is BPD. So the diamond is clearly away from the null line. And if you look at the pooled effect size, it's 0.69. That means 31% reduction in BPD if you give early surfactant when compared to late surfactant. And the confidence interval does not cross 1. So there is about 30% reduction in BPD if you use early rescue surfactant. So start CPAP, the baby requires high FiO2, immediately early rescue surfactant. Now, if you give surfactant, how are you going to give surfactant? So there are many methods, many new modalities coming up. So how are you going to administer surfactant? We'll talk about only 2 things. One is ensure, that's intubate, surfactant, and extubate. And we are looking at the evidence for ensure versus late or just giving surfactant and continuing on ventilation. But unfortunately, we do not have such clear-cut analysis of data. So here, this Cochrane review actually looks at ensure versus delayed surfactant and then continuing ventilation. So this is an effect of both delayed surfactant as well as ventilation, but short of evidence of really that explains ensure versus no ensure. We are looking at this, proxy, but still this here, let us assume that this is ensure versus no ensure. We are looking at BPD and we are looking at this pooled relative risk. It's not touching the, it's just about to touch, but it's not touched. So look at the confidence interval is 0.99, the upper limit, and 0.51. So this the number of studies are small, and then the only few studies have been studied, few infants have been studied. But still, whatever evidence we have, there seems to be a significant reduction in BPD if you give, if you do ensure than if you don't do ensure. As I said, it has its limitations, this review, but we take it as a proxy for insure versus no insure. So if you're going to give surfactant, you have to give early rescue. If you're going to give early rescue surfactant, then to do insure. So immediately give surfactant and immediately come out. And that's what the current recommendation is. Now, can we improve further from insure? Can we do something else that that will avoid even intubation altogether? And that's brings us to the topic of less invasive surfactant administration, what we call as a LISA, or something related is MIS, that is minimally invasive surfactant therapy. And this is about less invasive surfactant. So this is a meta-analysis published in 2017 that included 6 studies. And these are, I will talk about the studies, individual studies, but now, right now, we'll look at the pooled relative risk. Again, the diamond is not touching the null line. So you look at the confidence intervals and the pooled relative risk is 0.75. That means 25% reduction in BPD with LISA versus no LISA. It's just a control normal, how we normally do. So, and this confidence interval does not touch 1. So there seems to be significant reduction in death or BPD, about 25% reduction in death or BPD if you have to quantify, if you use LISA versus not using LISA. The 25% reduction is huge, but if you look at the studies, these are only 6 studies. The number of studies have been, number of studies is small, but the number of neonates enrolled is also small. It's only 100, 160s, 40s, and 90. So the number of neonates enrolled is not that high that to give enough confidence for us. And of these 6 studies, only 4 really mentioned whether they followed insurers in the control group or not. So looks promising, I would say, looks promising, Lisa, but there are our own unit's experience is that it's difficult to administer Lisa in many babies. You need a long learning curve. You cannot just go and then give Lisa in the first baby you would do. So it's a learning curve, but it's definitely it's in step in the right direction. So to summarize, whatever we have done, we have talked about in ventilation. We have CPAP, we talked about NIPPV, we talked about Ensure, we talked about LISA. So I will take the help of Isayama, who did publish a network meta-analysis on non-invasive ventilation strategies and BPD. So we, I think previous speakers, many people talked about network meta-analysis, so I'm not going to explain what is network meta-analysis. So this is what the figure looks like in this review. So we have many studies on nasal CPAP. About, for example, 7 trials comparing CPAP with Ensure, 2 studies comparing Ensure versus mechanical ventilation, 3 trials comparing CPAP versus mechanical ventilation, and so on and so forth. So we have different modalities, and then based something are directly compared, and some will be indirectly compared, and that's what network meta-analysis. So if put everything together based on the direct as well as indirect evidence, and you rank all these interventions, LISA seems to be ranked first. That means that is the highest for preventing death or chronic lung, or reducing death or chronic lung disease. And Ensure and non-invasive suppression, NIPPV, are ranked 2nd and 3rd. So this is again, you can see the first rank is LISA. This is LISA, and this is the next one, which is this is Ensure. This one. So it's mostly 2nd. And this one is the NIPPV, and that's 2nd, and this is 3rd. So looking at all the strategies put together, if I have to select most important ones, LISA and Ensure seems to be the best bets for preventing death or BPD. Now moving on from CPAP, we have to move ahead, because if you use CPAP, some babies might fail CPAP. So what if CPAP is going to fail? Now, the next question is, how many babies are going to fail CPAP? If you look at the data from COIN, Support, and other trials that are predominantly enrolled 25 to 29 weeks of gestation, the first week, about 60% could be managed just with CPAP. But about 40%, they fail CPAP and have to be intubated in the first week of life. And this figure increases to about 2/3 if take the full hospital stay. So about 2/3 will require ventilation, intubation and ventilation till they are discharged, and about 40% will require intubation and ventilation in the first week. So we cannot just stay put that CPAP and then surfactant and then LISA. That will help. but that is likely to fail, particularly in babies who are less than 29 or less than 28 weeks of gestation. So we need something else. And for that, we need to talk about mechanical ventilation. So from CPAP fails, then we talk about mechanical ventilation. So which mode to use if you are going to use mechanical ventilation? And traditionally, we have been using pressure control ventilation. That's what the bread and butter of most neonatologists. But the new kid in the block is the volume targeted ventilation. Now, volume targeted ventilation is basically using volume instead of pressure in a pressure control ventilation. So volume, because volume trauma has been in animal studies has been proven to be more damaging to lungs than barotrauma. So if you can directly titrate the volume, then you can reduce the volume trauma and thereby the lung injury and thereby the BPD. So that's the biological rationale why we need to use volume ventilation. But does the biological rationale translate into evidence? So again, I'm taking the help of the Cochrane review. This was published in 2017. This is volume targeted ventilation versus pressure limited ventilation. And the outcomes are, as usual, death or BPD, or here it is death or BPD. So we have a lot of studies which have strictly used volume ventilation, and there are some hybrid studies. And again, I'm going back to the diamond. It's clearly away from the line of no difference. And if you look at the pool relative risk is 0.73, and the confidence interval upper limit is 0.89, so it doesn't cross 1. So there is 27% reduction in death or BPD if you use volume ventilation in place of the traditional, what we normally use, the default pressure control ventilation. So it's time to move on to volume ventilation. And if that's a mode of ventilation, volume ventilation. Now, when you use ventilation or even in non-invasive ventilation, we should talk about what targets we are going to use. So we need the oxygenation targets and the ventilation targets. So what targets we are going to use? So predominantly, we are looking at low saturation and high carbon dioxide, high CO2 targets to prevent lung injury. So low saturation, we are talking about 85 to 18%, and high CO2, we are talking about 50 to 65 millimeters of mercury. And that's what we typically call as a permissive hypercapnia. So why we need to do either low saturation or high CO2 or both is because when you use low saturation, we are reducing the oxygen toxicity. And when we accept, that's when we do permissive hypercapnia, we reduce the volume trauma, and because we don't need that much pressures to eliminate the CO2, and reduce volume trauma as well as barotrauma, and that should prevent BPD. So what's the evidence? We'll see in subsequent slides. So for oxygen saturation, we have as I said, low saturation targets, which is typically 85 to 18%, versus 91 to 95%. That's a high saturation target. So we have the NeoProm studies published in 2018 by Ascieta. And these are the summary some measures, summary effect sizes of all the relevant outcomes. So if you look at BPD, that is supplemental oxygen at post-menstrual age of 36 weeks, if you compare lower saturation, that is 85 to 89, with higher saturation, this is clearly away from this null line. So there seems to be a significant reduction. And if you look at the pool relative risk, 0.81, and the confidence interval does not reach 1. And there seems to be a significant reduction in BPD if you use low saturation targets. But the problem is, if you use low saturation targets, you are actually causing a higher risk of mortality. So death before 36 weeks is 1.818. There is 18% increased risk of death. So if you use low saturation targets, you might prevent BPD, but you'll have more deaths. So ultimately, because of high risk of deaths and high risk of you have other issues. So we do not, particularly the of course ROP. We do not recommend. With the high saturation targets, you have low mortality. With high saturation targets, low mortality, but with the low saturation targets, we have high mortality. But on the contrast, you have reduced BPD. So you cannot take chances with the deaths. So currently, what is the evidence and the recommendation is to use high saturation targets because we do not want more deaths. So even at the cost of having slightly higher BPD, we do not want higher deaths. So we are going to recommend high saturation targets, that is 90 to 95% in preterm babies. Moving on to permissive hypercapnia, that is looking at slightly higher CO2 than the normal CO2s, which we normally have been talking about. So high CO2 is typically I am taking the help of Felby trial. So that is in the Felby trial, there are different CO2 targets at different time points, but I'm taking the third to second week, third day to 7. That is the high saturation CO2 targets are 55 to 70%. And sorry, it's not percent, it's millimeter of mercury. And control is 45 to 60 millimeter of mercury. So even the control group has a slight higher CO2 than what normally we use. So remember that even the control is actually a permissive hypercapnia. So this is, we are talking about 50 to 60 millimeters of mercury of CO2, even the control group. So if you have a high target CO2 versus the control, that what we call as a control, there's no difference in death or BPD. But the control group has slightly lower risk of death or BPD than the high CO2 group. So the message is that I accept slightly higher CO2, but not the heroic CO2s like 65, 70 or 75, but 50 to 60, I'm perfectly happy. So that's what I'm looking at when I'm talking about prevention of death or BPD. So that's about ventilation, that's about oxygenation, that's about CO2 targets. So put all together, this is again a summarize. So support strategies, surfactant administration, what are the things that work and what are the things that do not work. So here we have talked about CPAP, we talked about volume targeted ventilation, we talked about surfactant, we talked about LISA. And some of them as I specifically omitted because elective high frequency ventilation, almost none of us use elective high frequency ventilation preterm units immediately after birth. So I'm skipping that. And this is just synchronized on APPV is not widely available. So I'm skipping that as well. So put these four together, all of them are clearly away, all these four are away from the null line. And if you look at the number needed to treat, it's 25, 9, 29, and 12. So these are, from the public health point of view, these are very good numbers for number needed to treat. And the best bets among them is like for volume ventilation and LISA. So if you are going to move with the ventilation, so think of volume ventilation. And for surfactant, think about LISA in your unit. Try to learn and then start using it. That sort of stops the ventilation strategies. And moving on to medications. Before that, I will ask Dr. Murki or Dr. Shikesh, can I go ahead? Because I have another set of slides, which might take another 20, 30 minutes.
Please carry on. I think people are willing to listen.
I hope there's not information overload and people are not tired.
I don't see anybody saying to stop. I think we can continue.
Please carry on.
Okay, thank you. So moving on to medications, I'll start with caffeine. Caffeine, we all know the interest in caffeine for prevention of BPD is essentially from the CAP trial, which is a caffeine therapy for apnea prematurity published by Barbara Schmidt in EGM. And that showed, BPD was actually a secondary outcome that showed a 36% reduction in BPD. There's sort of a really remarkable result which they showed. And there are so many theories put together why possibly it reduces the need for ventilation, it reduces the duration of oxygen, and so on and so forth. But the bottom line is that it reduces BPD. And if there's no doubt about caffeine reducing BPD, but in that case, when we are going to start BPD, and it should be early or it should be late. And that's this is a systematic review done by Pakvasa in that is published in Clinics in Perinatology. As a review, it was a review, but they actually did a systematic review. They looked at different studies that initiated caffeine at a different time points. So these are there are only a few RCTs, but predominantly observed studies. So this is early versus late. Early here in this study is 0 to 2 days. In this study is 0 to 2 days. In this study, it was 1 hour versus routine is about 12 hours. So very early they are starting in some studies. And these are observation studies. So if you look at these studies, and you can see this is on this side is favoring early caffeine, and this is favoring late caffeine. And the outcome is BPD again, so BPD. So it's 0.69. So this diameter is not crossing the null line or the line of no difference. And you look at the confidence interval, it's 0.64 to 0.75. So there's clearly this confidence interval does not cross 1. So there is significant reduction in BPD if you use early caffeine. So the message is that in preterm units, so in less than 28 weeks particularly, you start caffeine early. The first day, if any preterm baby less than 28 weeks or less than 29 weeks, that you can titrate depending upon the prevalence of BPD in your unit. Less than 28 weeks, the baby requires, if the baby has any respiratory distress, you start caffeine as early as possible in the first day to prevent BPD. That's what our AIMS protocol is. Moving on to vitamin A, I have only one slide. So we know vitamin A, this is helpful. This is the Cochrane review, and we have, this is chronic lung disease, the outcome is BPD, and this diamond is just abetting us, but it's not touching the line of no difference. So you look at 0.85, it's a pooled relative risk. So there's a 15% reduction in BPD. If you give intramuscular vitamin A, remember this is about 5,000 units every other day for about 4 weeks. That's really, really a lot, but it's only 15% reduction. But still, it's one of the few therapies that have been proven to be beneficial in preventing BPD. So that's vitamin A. But currently, it's not, as far as I know, it's not freely available in India. So we are not using, and it's costly. And more important, it's intramuscular injection. It's painful to have 28 injections or that many injections. So it's really painful for the baby. So the risk-benefit ratio possibly doesn't tilt towards benefit. So even in the best centers, the developed countries, they are not routinely using vitamin A. From caffeine, vitamin A, we move on to postnatal steroids. That's sort of the most important part of management of BPD, also the controversial part of management of BPD. So why steroids? Steroids because it reduces the, it's anti-inflammatory, it reduces pulmonary edema, it upregulates beta-adrenergic activity, it induces surfactant synthesis. So it sort of tries to cover everything. And you know, this is a potent anti-inflammatory agent. So if inflammation is the key, steroid should be the key for prevention of BPD. And that's the biological rationale. And when you talk about steroids, it's not simple, because when you talk about steroids, you have systemic steroids, you have inhaled steroids. In systemic steroids, you have dexamethasone, you have hydrocortisone. In inhaled steroids, you have early as well as late. Again, in dexamethasone and hydrocortisone, you have early and late. Early typically is less than the first week, there is 7 days or less, and the late is more than 7 days. On top of that, we have low dose versus high dose. So it's really confusing. So steroids, we have multiple routes, multiple drugs, multiple time points, and multiple dosages. So it's really confusing. I've tried to simplify. So if you look at only early steroids, and I'm just talking about death or BPD. So we have dexamethasone, and this diamond is away from the null line. So there is a significant reduction. There is 13% reduction in death or BPD if you use early dexamethasone, that is in the first week. And what about hydrocort? Again, there seems to be reduction, but 10% reduction, it's almost touching 1. So there is a reduction with both dexamethasone as well as hydrocortisone in death or BPD. And the pool is also saying the same. So both are, it's about 12 to 13% reduction in death or BPD. Now, that's the efficacy part. What about the safety part? If you look at the cerebral palsy, with the early dexamethasone, that is in the first week of dexamethasone, the number of studies are not that high, but you can see that it's 1.75. That means 75% increased risk of cerebral palsy if you use early dexamethasone. But with hydrocortisone, there does not seem to be any higher risk of cerebral palsy. Both put together, there seems to be about 40% reduction, 40% increase in cerebral palsy if you initiate early steroids for prevention of BPD. So on one hand, it's efficacious, but on the other hand, it is not safe. So it's 70% increase, but predominantly with dexamethasone. Now, what about late steroids? The late steroids, if you look at death or BPD, again, this the diamond is not touching the line of no difference. It's about 23% reduction, and in death or BPD, if you give late steroids. And what about cerebral palsy? Cerebral palsy, this you can see, this is touching the line of no difference, 1.1. So there's about 10% increase, but this is clearly crossing. Then the confidence intervals are crossing the line of no difference, crossing 1. So there is no significant increase in incidence of cerebral palsy if you use late steroids. And what about inhaled steroids? Death or BPD seems to be reduced. So about 14% reduction in inhaled steroids. So to put it again, to summarize, early steroids is effective, but not safe. Early dexamethasone, we are talking about early dexamethasone. Late dexamethasone is effective and safe because it doesn't seem to increase the risk of cerebral palsy. early hydrocortisone seems to be efficacious, but it increases the risk of GI perforation. So not a CP, we do not have much evidence to that it increases the risk, but the short-term side effects are still there. And inhaled steroids seem to be reducing the risk of death or BPD. Now, again, I will take the help of a network meta-analysis to summarize the corticosteroids. So this is published in 2018. This is what the diagram looks like. So we have low-dose dexamethasone, high-dose dexamethasone, inhaled steroids, and you have placebo, you have hydrocortisone. But these are very only few studies. Predominantly, we have low-dose versus placebo studies. Put everything together, we look at the direct evidence as well as indirect evidence, all evidence put together. What it seems that dexamethasone, whether it is high dose or low dose, will reduce the incidence of BPD. So it's about a significant reduction. This is about 80%, this is about 70% reduction, this is about 40% reduction. And if you look at others like hydrocod, budesonide, fluticasone, and beclomethasone, they do not seem to reduce the risk of BPD. So this is based on the network meta-analysis. And cerebral palsy, dexamethasone high dose seems to increase the risk, but low dose doesn't seem to increase. But both are not significant, remember. But here, one direct evidence is high dose increases, low dose doesn't. Put everything together, possibly it doesn't increase the risk of cerebral palsy. So this is what I said. Dexa low and high dose reduces BPD at death. Possibly, we do not know, but if you look at all the evidence, possibly it doesn't increase. But look at the direct evidence, possibly dexamethasone increases the risk of cerebral palsy. So put everything together, the number one rank. So for BPD would be high dose dexamethasone. But if you put CP as well as BPD put together, so we are looking at low dose dexamethasone for prevention of BPD. So low dose dexamethasone seems to be preferable for preventing BPD in babies, in preterm babies. But the next question is, who will benefit? Can we give low dose dexamethasone for every baby? So that's the million-dollar question, because on one hand, you have increased risk of CP. On the other hand, you have lower risk of BPD. So we need to balance out, and then you have to choose a population just who are at higher risk of BPD. And for that, we need something like, we need to know the risk of BPD in the control group. So this is one of the most quoted papers by Doyle et al., published in Pediatrics in 2005. This is effect modification by the risk of BPD in the control group. I will explain, it looks a little difficult, but it's much easier. So what it says is, on the x-axis, we have chronic lung disease in the control group, and on the y-axis, we have the effect of death or cerebral palsy. So when the risk of BPD in the control group is lower, the death or BP, actually, this will favor the control group. That means death or cerebral palsy will be higher in steroid group. But when the risk of BPD becomes more in the control group, you can see at the bottom part of this figure, or the right-hand part of the figure, if the risk of BPD is higher in the control group, then the death or CP will reduce in the steroid group. So we need to know the risk of BPD in the control group. So if the risk of BPD in the control group is about 35% or low, then steroids will be harmful. But the risk of BPD in the control group is 65% or more, then steroids will be beneficial. Now, the next question is, we'll talk about, this is what I said, risk is less than 35%. The risk steroids will increase the risk of death or cerebral palsy. The risk is more than 65%, steroids will decrease the risk of death, cerebral palsy. But when you are going to treat a baby, there is no control group. So what is risk of death or cerebral palsy in a control group? And that is given by, so how to estimate the risk of BPD in the control group? So to put it simply, the risk of BPD in the control group is equal to risk in a given baby. So if I can estimate the risk in a given baby, the risk of BPD in a given neonate is more than 65%, that baby qualifies to receive low-dose dexamethasone. That's what it's in simple terms it means. But how will I know the risk in a given baby? For that, we need to know something like a calculator. So this is the NICHD BPD calculator that uses variables like gestation, birth weight, sex, race or ethnicity, postnatal day. This is done at 7th day, and what ventilator the baby is on, which mode, whether it's NIPPV or CPAP, and what FIO dose. These are very simple variables, and you just put this for, we have just filled for one baby, and you click calculate, and it will give the risk of death, the risk of severe BPD, moderate BPD, and mild BPD. That is, with this death of severe and moderate BPD, if it is more than 65%, then I am okay to give low dose dexamethasone in a particular baby. So this is useful. But the problem is the race or ethnicity is predominantly what is given in NICHD is only for Caucasians and Hispanics and Black. That's what the typical population in any unit in the US. So that's obviously they're not targeting us. So with that as a you take that as limitation, then you look this, use this calculator, and then you can look as a risk of BPD in a particular baby. So we try to validate using this score, and we used either Hispanic or Black. That didn't change much. So about 4 babies we used. So these babies all developed severe or moderate BPD, and they were all on mechanical ventilation by day 7. So on day 7, we try to validate what actually the score says. So about 3 babies, it said that 60 to 70% risk of moderate or severe BPD, which is quite good. And in 1 baby, it failed. So it seems that it's quite good. But it's, of course, this is nothing. This is like anecdotal evidence because only 4 babies. But there needs to, first of all, we need to sort of develop a calculator and then to validate such calculators to identify the babies who can benefit by giving postnatal steroids. So that's the research priorities. One of the research priorities is to have a risk calculator for Indian units. So one of the proposed algorithms is what we try to use in our unit is an extreme preterm. If the baby is on ventilator after a first week, that's in the day 7 of life, you assess the risk, and the risk is more than 65%. You give low dose steroids. So as I mentioned, the DOT regime, there is 0.89 milligram per kg cumulative over 10 days. That's what we try to follow. So from there on, from medications which are proven to be effective, we move on to therapies that have been used again and again, but they are largely unproven or proven to be ineffective. And that's, we start with the sustained lung inflation at the time of resuscitation. So sustained inflation stands for inflating pressure held for a prolonged duration. That is about more than 5 seconds during resuscitation. So you keep the pressure for about 5 seconds, and during resuscitation, that will inflate the lung, and that will sustain that inflating pressure for a long time. What is the rationale? It will clear the lung fluid faster, and therefore aerate the lung better, and therefore it will reduce the need for subsequent ventilation. What is the evidence? Clearly, there's no difference in bronchopulmonary dysplasia, and the meta-analysis and the largest trial actually showed increased risk of death in the first 2 days after birth in babies who received sustained inflammation at the time of birth. So clearly, sustained inflammation is no, it's not to be done. Now moving on to fluid restriction. So fluid restriction, we have a Cochrane review, but there's only limited data. What does it actually mean? Fluid restriction means restricted fluid intake in the first few days to first 2 weeks of age. So each study, actually about 4 to 5 studies, each study used different intervention in the control group. But why it should work? Because excessive fluid, as I mentioned in my pathogenesis figure, so excessive fluid intake will lead to pulmonary edema and therefore increased respiratory support, and therefore increased inflammation, and so on and so forth. The evidence, whatever limited data we have, we do not have any clear benefit in terms of BPD. Of course, it reduces something else. It reduces even NEC and other things, but it doesn't reduce BPD. So fluid restriction just for prevention of BPD is not necessary. It reduces NEC, it reduces PDA and death, but not BPD. Diuretics, which are commonly used, we have loop diuretics and we have thiazides. And why do you use? Diuretics reduce pulmonary edema, and definitely have been shown to improve the compliance of the lung and reduce the resistance of the airways. So in both ways, it should reduce inflammation and then BPD. But only limited data, only short-term improvement, no long-term improvement with diuretics. So diuretics for prevention of BPD is not proven. There are only a select group of babies where you have a lung X-ray features of pulmonary edema. You can use for a short period, but as a default response to prevent BPD, diuretics are strict no. Treatment of patent ductal sarcoidosis. in the form of medical or surgical management of patent episodiosis. Why? Because there is strong association between, from observed studies, strong association between PDA and later subsequent risk of BPD. But the evidence says that prophylactic closure of ductus or treatment of a symptomatic ductus has not consistently shown to reduce the risk of BPD. So you want to treat BPD because of other reasons, but not for prevention of BPD. That's about therapies which are not proven or which are not effective. Now, the next part is about promising therapies which we have for BPD. This is azithromycin. There's some, we know there's a macrolide antibiotic which has microbial and anti-inflammatory properties. Why it should work? Because ureaplasma is an atypical organism has been sort of proven to be associated with the development of BPD later. In subsequent, that is the postnatal age. So in that case, azithromycin acting upon in the first week or 10 days should reduce ureaplasma colonization, that reduce BPD. And what is evidence? It's a low quality evidence that reduces the risk of BPD or death of BPD in babies who are given azithromycin. But it's low quality evidence, only limited data. So there is a need for more studies. And what about the next is steroids with surfactant, intratracheal steroids with surfactant. So when you give surfactant, you give intratracheal steroids mixed with surfactant. And that is intratracheal budesonide in the dose which is mentioned here, along with surfactant. Why? Because because you're putting into the trachea, it should have strong local anti-inflammatory effect, and therefore it will reduce the inflammation in the first week and thereby reduce BPD. But this limited evidence, and but that showed a significant reduction in the risk of BPD. Again, there's a need for more studies before we jump into this region. There are other modalities that have been tried and there are under evaluation. There is like a RHCC, there is a recombinant human club cell protein, there is a Clara cell before we used to call. There's a phase 2 trial in progress. Inositol, there is a phase 3 trial in progress. Cell therapy, there is stem cells. 5 trials are ongoing using mesenchymal stem cells. And one trial, which very few number, only about 9 babies or so, showed that it's actually safe, but we do not know whether it will be effective or not. So these are under evaluation. Again, so there is a need for more studies. So that's what the evidence is for the medications, and then the proven and unproven therapies, and then ineffective therapies. So if I have to summarize everything together, at the antenatal period, we have antenatal steroids. At birth, we have delayed cord clamping. Again, I have not touched upon it, but delayed cord clamping compared to early cord clamping, it does, one of the effects is that it reduces BPD and ensure optimal functional residual capacity by initiating delivery from CPAP. We give CPAP, early risk surfactant, fluids, normally what we use. And if you're going to use, maybe required surfactant, early risk surfactant, use phosphates, adequate PEP, and use early caffeine. That's what we do in the first 24 hours. The first week, this is about fluids. You be on the safer side, on the restrictive side, even though there has not been shown to be beneficial. Nutrition is, again, I have not touched upon. Nutrition is definite yes for BPD. You have to have adequate nutrition. So TPN the first week, and then slowly increase enteral nutrition so that infection is prevented, and extubate to CPAP as early as possible. Again, if you're not started caffeine, like 20 to 32 weeks, you have to post-extubation, you have to start caffeine. And if it's available and if your unit protocol is allowing to do that, you give IM thrice weekly vitamin A. And of course, these you should not forget the supportive care. And 2 to 4 weeks, we have fluids and nutrition. Steroids, if a baby is extremely low birth weight or extreme preterm, stuck on ventilator in the second week, then you give steroids. This will translate to risk calculator of about 65%. Diuretics, as I said, only if there are features of pulmonary edema. Bronchodilators as a default, no. Only if there is clear evidence of bronchospasm, and more than 4 weeks is what we talk about treatment. So treatment, we do not have much for BPD. So you have to give enough nutrition. And ventilator settings, I'm talking about treatment. I will talk about treatment of BPD, what ventilator settings we need to use. We have only bronchodilators, only if there is a bronchospasm. And BPD spells you have to manage by increasing the PEP and maybe sedation and muscle relaxation, depending upon what mechanism of BPD spell is operating in a given baby. So for treatment, unfortunately, we do not have much. One thing which I wanted to highlight in the ventilation strategy while treating a baby with established BPD is to use slightly different settings than we would normally teach. So when we teach audio settings, we use short inspiratory times, high rate, fast rates, and a low tidal volume. So that will help in a baby with ODS. But in a baby with BPD, what will happen is you have a heterogeneous lung disease. This segment is a normal compliance and normal resistance. This segment has low compliance and low resistance. And this segment is high compliance and low resistance. And this segment is normal compliance and high resistance. When you use the strategy of ODS for a baby with established BPD, then you will end up ventilating a high compliant part of the lung, and all other parts are underventilated, and that will further lead to lung injury. So what we actually need to do is a high tidal volume, a long inspiratory time, and a slow rate. So that's what we use. In that case, you can sort of expect to ventilate all the parts of the lung. And that's what, so the ventilation strategy you have to change when the baby goes from first week and then to evolving BPD and then to established BPD. You have to change your ventilator settings. And moving on to the research ideas which we have, we can have, so most of you being fellows, what all the topics which you can think of is, one is the burden. There are positive studies there's a positive studies from India. Burden itself, long-term outcomes, pulmonary outcomes, neurodevelopmental outcomes in infants with the BPD, rehospitalization rates, RSV, for example, respiratory syncytial virus and other viral infection, and need for hospitalization because of that, the need for monoclonal tavrismab, for example, risk calculators, a specific Indian risk calculator for predicting BPD so that we can titrate our therapy, including steroids and other treatment for babies with BPD. Most optimal corticosteroid, most optimal regime, most optimal drug. Clinical trials on LISA or MIST versus Ensure and other modes. Timing of initiation of caffeine. Inhaled steroids with surfactant versus only surfactant. Macrolide antibiotics, stem cells. And I think this is my last slide. I'll be happy to take the questions. Thank you.
Thank you, Jeeva. I think it's an excellent presentation, and as usual, you make it very simple. Although it is such a difficult topic, but you did it such a great job that, and it is much easier to understand the topic now than at the beginning. Now, obviously, there are questions. DART versus Minidex, which is better? Jeeva, can you hear? Jeeva, you are mute. Jeeva, can you hear?
Yes, I can hear you. Yes, please.
DART versus Minidex, which is better?
The most optimal regime is not known. The least possible dose I would prefer. So whichever has the least possible cumulative dose, you can use that.
Are Indian babies more risk of BPD if we take out chorioamnionitis as a risk factor?
Possibly, yes. Possibly.
What is the role of vitamin oral?
No, the limited data shows that it's not effective.
Any role of fluid restriction in week 4 to 7 of life? Week 4.
Doesn't seem so. It should be, if at all, if it has to act, it should be in the first 3 weeks, particularly between second and third week. From fourth week, I don't think lung edema is the major pathogenesis or pathophysiology in BPD.
Any difference in incidence of BPD using CPAP with different interfaces? I don't think there's an evidence.
No, I don't think there's any difference. I think you are the best person to ask.
Yeah. Any role of bronchodilators?
As I said, bronchodilators do not have much role. It's to be used only if you have a clear-cut evidence of bronchospasm, and that is just for short term. It does not have any role in preventing or preventing BPD. Yeah.
Any difference in the type of surfactant, artificial, natural, bovine, porcine?
Natural surfactant is definitely better when you compare to protein-free synthetic surfactant. But if you have a recombinant synthetic surfactant, there is no difference. And bovine versus porcine, the person is better in terms of reduced oxygen requirement the first few hours, but that is because of higher dose, initial dose, not because of any major other difference. There is no major differences in terms of other outcomes.
We know that steroid is sparingly used, but if we have to use, do we screen for sepsis before, or how do we avoid sepsis when we give steroid?
We don't have to screen, only clinical examination is enough.
Any role of stem cell therapy?
Right now, no. As I said, it's a research priority. It's experimental.
Low dose hydrocortisone in intubated babies. Hydrocortisone.
Yeah. Low dose hydrocortisone. The first week, the Prologue study did show a significant reduction, but I would say that wait for more evidence.
What is the ideal tidal volume for volume ventilation to prevent BPD? To prevent BPD.
To prevent BPD, for ideal tidal volume.
Yes.
So as I mentioned in my last slide, so we talked about a low volume. So typically 4 to 5 or 4 to 6 ml per kg in the initial stage of ODS, and then if the baby goes on to evolving BPD and established BPD, in that case I would use a slightly higher, about 6 to 7 or so.
How do you manage BPD spells?
BPD spells is a very, BPD spells itself, like the disease itself, it's heterogeneous. So you can have BPD spells because of bronchospasm, but also you can have BPD spells because of baby being irritable, or because of bronchomalacia. So if the spell is actually because of bronchomalacia, you have to increase the PEP. Bronchodilators will actually going to worsen. If the spell is because of bronchospasm, then you have to use bronchodilators. The increasing PEP is going to worsen. So you have to be at the bedside and then examine the baby and then see. And then you have to take a call whether if there is a clear, if there is some clear, so for example, V's, then I would prefer bronchodilators and I would have a lower PEP. But if there is no V's and the baby is like sort of agitated and having so like more of a malacia type, in that case, I would increase the PEP and give sedation and then.
There's one question. If what is the role of steroid in new BPD? Because new BPD is more of alveolarization problem. How steroids are going to help in them?
Yeah, it's not. As I said, all these medications and therapies are predominantly for old BPD. But in India, we are not even sure. We are having a lot of new BPD or a lot of old BPD. As far as I know, we are having even between babies between 28 and 32 weeks, and that is predominantly old BPD. So all these things do matter in India. What is the role of RSV prophylaxis? As far as I know, the RSV that this thing is not available in India, so it's theoretical.
Erythropoietin?
No. For BPD prevention, as far as I know, no.
Do you know of any BPD mimics?
BPD mimics?
Something which presents a BPD, but we should
like something like ROP mimic. I'm not aware of it. So we had a case of BPD which had a collateral. Okay. It was a very significant collateral requiring prolonged oxygenation, prolonged ventilation. And in fact, we had to close the collaterals. We did a coiling of the collaterals and the baby improved dramatically after that. Okay. They are reported, case reports are there, but collaterals are, they could be primary or they could be secondary to prolonged lung disease itself. Okay. Is chest X-ray finding a compulsory to define BPD? If you don't have to, at 36 weeks, you don't have to do X-ray just to define BPD. If you have previous X-rays that showed parenchymal abnormalities, that's enough. Okay. It's not that you are likely to have you have baby with no previous X-rays. If your previous X-ray shows some parenchymal lung abnormalities, that is more than enough. You don't need X-ray, a new X-ray to define BPD. It is so difficult to differentiate BPD from pneumonia. So if X-ray is looking, a lot of infiltrates are there, how are we sure that it's not pneumonia and start steroids? Very difficult, very difficult. So one thing which can help is you look at the definition for VAP, ventilator associated pneumonia. A new infiltrate, or you can look at the counts. and maybe a biomarker like procalcitonin. So it's, of course, it's not foolproof. These are not foolproof strategies.
Yeah. So I think if it qualifies for VAP, I think we should try to treat VAP and then take care of the BPD.
Yes.
So I think that's all. I think it was a lot of questions. Rishi, you have anything?
Yeah. Jeeva, you talked about IUGR as one of the major contributors, and especially in our country. So how does IUGR differ in terms of chronic lung disease?
Okay. IUGR, I didn't actually, I mentioned, but I didn't have any slides on IUGR. I predominantly talked about chorioamnionitis. IUGR is definitely the traditional belief, what many people even now believe is that IUGR sort of causes precocious lung maturity, and therefore it should prevent BPD. But that has been proven to be wrong. It doesn't work that way. IUGR is a risk factor for BPD. And possibly because of the stress and the stress-induced inflammation, and that inflammation, top of that, when you have injury because of polytrauma.
It's 10 o'clock.
So you have injury, top of inflamed lung, that should cause more BPD.
Any specific interventions meant for that?
As far as I know, you have to prevent IUGR.
Okay.
I don't think any specific interventions.
And your take on inhaled steroids?
Inhaled steroids. Based on the network meta-analysis and the evidence, other evidence, right now it's not useful for prevention of BPD. I would say rather, if I have to give steroids, I would rather give, right, for the time being, I would use low dose. But of course, these are dynamic. If the new evidence, we might change our practice.
And the last question, is there any role of montelukast?
No, leukotriene antagonists have been proven to be not effective.
Thanks. And it's very exciting to learn from you again and again.
Thank you. I think Jeeva, we had 400 people attending for this lecture for today.
Thank you.
So I think a lot of questions were there, and then I think many of the doubts have been cleared with the management and prevention of BPD. So we are happy to have you, and thank you so much for coming for today's lecture. And yeah, we go ahead with the poll now, Rishi.
Yeah.
So just a minute. Before I start with the poll, I think I'll share the screen for tomorrow's, because tomorrow's is going to be the last day. And also tomorrow is going to be one of the days where we are going to have 2 lectures as a special case, because we wanted COVID to be discussed. And tomorrow we have one panel. Just sharing the screen for the panel. So tomorrow, this is a panel on COVID. All your doubts on perinatal COVID will be cleared, and we have a live chat. Dr. Praveen Kumar from PJ Chandigarh is going to steer this. And we have all the experts, Dr. L.S. Deshmukh sir, Dr. Kiran More, and Dr. Deepak Chawla, Dr. Sindhu, and Dr. Ashish Jain. So these people are going to be there with us at 1:30 p.m. tomorrow. So please come and join us. And so we hope each one of you will be coming to join us tomorrow at 1:30 p.m. And tomorrow evening is the last lecture for this session of lockdown. So we are not going to extend, because we thought we'll give you some time more to read at the things which are already been done. So all the lectures are available on YouTube. Those which are privately shared. There are only some lectures which will be privately shared on your mail again tomorrow or day after. So please go through them. Yeah, tomorrow's time for the panel is 1:30 p.m. and also 8:30 p.m. So now I'll open the poll for yesterday's markers for malformation. I request all of you to start taking the poll. Can you see the questions? Yes. Okay. Rishi, meanwhile, you want to share your screen? Link is the same like today. The same link will work both at 2:30, 1:30 as well as at evening. No lectures after tomorrow. Tomorrow is the last day for lectures. We are trying to see if we can have a monthly or a weekly lecture. We will try to get back to you because we have all your email IDs, and we will try to see if we can do such webinars at least once a month with the best experts all over the world and country. Yeah, I think all the mails will be available. We will share. The links also will share on all the WhatsApps so that some of you don't get on the mails can get through the WhatsApp also. Many people are asking for Dr. Naveen's lecture. I'll talk to him, and if he's willing, then maybe sometime in this week we will have and we'll intimate to you. Yes, Dr. Jeeva's lecture is already available on the YouTube. It's a live lecture.